Good morning, everyone, and welcome to the Thursday, August 27th presentation of Improving Patient Experience in Virginia Hospitals and Health Systems as part of the 2020 Year of Patient Experience celebration at the Virginia Hospital and Healthcare Association. My name is Abraham Segrist, and glad to see so many of our colleagues from across the Commonwealth with us this morning. Before we get started, just a few housekeeping notes. This webinar is being recorded. All of our participants are in a listen-only mode. In order to ask questions or make comments, you can do so by placing your questions or comments in the question box to the left of your control panel. There will be an opportunity to type information into this box later throughout the presentation. So if folks don't mind, if you could maybe chat in the name of your hospital at this time, so we can just give you an opportunity to be familiar with that function. The slides and recordings from this webinar will be available on the VHHA website early next week. We will also prepare an executive summary of the webinar and place it on our website as well. At the conclusion of this afternoon's webinar, a brief feedback survey will be launched, and we ask that you take a few minutes to give us your feedback. Today's agenda, I will review the specific objectives for our webinar, and then our primary presentation will be by Mr. Nathan Cunningham, the Manager for Patient Experience in the Department of Patient-Centered Services at Virginia Commonwealth University Health System here in Richmond, Virginia. Nathan will then be followed by our colleague, Carrie Brady, who will facilitate a few polling questions and discussion at the end of the webinar. Just a brief reminder, the Virginia Hospital and Healthcare Association is an alliance of hospitals and health delivery systems across Virginia, and our vision is that through the power of collaboration, the association will be the recognized driving force behind making Virginia the healthiest state in the nation, and our mission statement is there on the screen as well for your review. In regards to the organizations that make up the Virginia Hospital and Healthcare Association, they are listed there on your screen, and they include all of the acute care and rehab and behavioral health facilities across the state of Virginia. As I referenced at the beginning, our board of directors, in conjunction with the VHHA leadership, did declare 2020 the year of patient experience. We will note that we were not aware that 2020 would also be the year of COVID-19, but for those of you that have been with us through the last few presentations, we've clearly appreciated the fact that ensuring a solid patient experience continues to be important even during the course of a pandemic, and potentially more important. The goals for this year-long celebration is to identify and highlight efforts by Virginia hospitals to improve the patient experience of care, to be sure that we're integrating patient experience with our other broader quality and safety and clinical improvement efforts. We want to provide this forum to connect hospitals across the Commonwealth so that you can share what you're doing and learn from each other. And then the ultimate goal, of course, is to improve your individual and aggregate performance on patient experience as measured by our patients and our families. So the objectives for today's presentation, one, to understand the relationship between employee engagement and patient experience, to recognize common engagement challenges and strategies to overcome issues that organizations might face, and then to describe an innovative model for peer-driven design and development through shared decision-making. So it is now my pleasure to turn the presentation over to Nathan Cunningham from the Virginia Commonwealth University Health System here in Richmond, Virginia. Nathan?
Thank you, Abraham. Good morning, everyone. VCU Health is a comprehensive academic medical health system based in Richmond, Virginia. We have two hospitals, a downtown medical center in Richmond and a community hospital located about 60 miles south, closer to the North Carolina border. As a health system, we have over 740,000 annual ambulatory clinic appointments spanning across many central Virginia locations. VCU Health System is also composed of the Children's Hospital of Richmond, providing top-ranked pediatric comprehensive care. So I thank you all for joining me today to talk about this very serious issue confronting us daily. Cake. To have it or to eat it. Now, I promise I won't continually speak in mutated Shakespearean idioms, but this really is a fantastic way to frame the ongoing tug of war between designing employee engagement improvement and patient experience programs. As we all know, the relationship between employee engagement and patient experience has really evolved from a chicken or the egg conversation into the understanding of a symbiotic relationship. Yet there's still belief in the industry that successful improvement initiatives must focus on one or the other. So why not design an improvement initiative that simultaneously improves both? Let's have our cake and let's eat it too. So we have found that in patient experience initiatives, the ones that emphasize consistent, repetitious patient interactions really does create an environment of well-managed patient expectations and alleviated anxiety. Consequently, this does result in restricted autonomy of that team member in their daily role. Loss of personal autonomy in a job function and lack of inclusion in the decision-making process of patient experience initiatives or other initiatives will often yield disengaged team members. And as we now know, the disengagement of team members really manifests itself in lower retention rates, decreased trust in organizational leadership, and impaired critical thinking in situations of consequence. The keystone to simultaneous improvement in team member engagement and patient experience is truly organic in nature, and it falls within team member-driven strategies that can be uncovered through shared decision-making. Now, there is a very unusual paradox associated with patient experience improvement practices. As leaders, we are often healthy people sitting in comfortable chairs in private conference rooms, designing experiences for unhealthy people sitting in an uncomfortable setting with sometimes very limited privacy. Now, the industry is improving on this core fault, as it has made fantastic growth in providing the patient with an active voice in the improvement of their healthcare. Through surveying, focus groups, patient and family advisory councils, and many other avenues, patients now have the greatest impact on their healthcare than they ever have before. And hospitals are really reaping the benefits of this inclusivity and shared decision-making, as shown through the continuous increase in quality, safety, and service metrics that we see industry-wide. Yet we fail to follow this same shared decision-making principle within our own hospitals with our staff and team members. At VCU Health, we have a different approach to improving patient experience that really has emerged over the last few years, and that's what I'm here to highlight today. A shift in focus towards the enhancement of our team member engagement takes shape in the form of reinforcing a sense of workplace pride, while simultaneously harnessing those internal motivating factors that brought our team members to healthcare. We know that healthcare is the most empathetic field in any industry. We have to reharness those motivating factors with our team members. And this method really naturally empowers the most engaged team members to organize their talents, their passions, and their efforts to become active stakeholders in the advancement of the organization's mission. These groups of team members are now actively participating in shared decision-making across the highest levels of our organization. Engaging frontline team members in this fashion duly impacts their engagement while also improving our patient experience. Our frontline team members are able to identify patient suffering and process deficiencies in far more detail than any data set that leadership can uncover by looking at it in our offices. So these photos of lobby chairs is really what originally drove me to start working with frontline team members in this shared decision-making process. So we were very excited to update a new waiting lobby at one of our physical therapy clinics. The chairs on the left, in the left picture, were the original seating, and the new softer, more comfortable seating is what we brought in during the refresh. After a few months of the clinic reopening, we did notice a slight uptick in safety events reported in this area. So we followed our safety incident reporting protocols, and our performance improvement team started investigating what was happening. And during this investigation, it involves interviewing several team members. So when we interviewed those team members in the work area, we found that the new chairs were actually about 8 inches lower to the ground. Patients with lower extremity physical therapy appointments were having a very difficult time getting out of these chairs safely and stabilizing their balance, which did unfortunately lead to some injury with fall, or to some falls with injury. This is a prime example of how healthy administrators in comfortable and private offices were letting down our patients and our team members by not engaging them and having their decision-making at our table. So I decided to trial this new shared decision-making strategy by focusing on a patient experience improvement with one of our areas. I decided to target a patient access registration team, which I'll henceforth refer to as PAR, P-A-R, at one of our outpatient clinics, which is actually located on the screen. You can see it's a beautiful, brand new building, but engagement scores were falling beneath our organizational average, and the CG CAPS office staff quality metrics really plateaued around that 40th percentile range when benchmarked against academic peers in the Press Ganey database. So clearly, the PAR team really warranted our attention. Our entire PAR team in the organization spans over 340 team members, and they really are crucial to the success of managing over 3,000 outpatient clinic visits per day. They hold a very unique aspect in patients' experiences, because if you think about their physical location in the environment, they provide that first and the last interaction of each visit. So the goal of this work was to really empower the PAR leaders, meaning the supervisors or even informal leaders within those pockets, to create targeted initiatives at improving patient experience. I pulled together a group of PAR leaders, again, supervisors and some informal leaders, from this building location to begin collecting their thoughts on what improvement opportunities we could work on. Several identified initiatives were organized and then delivered back to the PAR teams from the leaders I met with, and they were best practices. They were evidence-based best practices that really should have worked. So after 4 months of working with this group and implementing several of these changes based upon their feedback, I wasn't seeing any data improvement. And the same supervisors and PAR leaders that I was working with were actually relaying back some frustration from this new work that they were hearing from their teams. So we recognized that really we were unintentionally sacrificing employee engagement from the frontline team members by solely focusing on just patient experience initiatives and not giving any attention to the new efforts and the new responsibilities I was piling on and asking them to do. I really hadn't gone deep enough into our frontline team members to start driving a true shared decision-making model. So while I thought that tapping into the PAR leaders, the supervisors, was such an innovative way to engage in shared decision-making practices, I hadn't even scratched the surface. The perception from frontline team members was that these initiatives were still coming from a top-down approach via their leaders and from me. So truly, I failed. So I reconvened the same PAR leaders that I originally met with to review everything that we had been doing and also start talking about team member engagement practices. It was really important for me to hear their recommendations about how we can reconstruct these initiatives that we, the leadership, designed without a true decision-making model. So at the end of that conversation, we were able to identify that actually not a single one of the previously implemented initiatives were actually frontline team member ideas. They were ideas that we brought in from evidence-based best practices that I had brought to the table, that a few of the supervisors had brought to the table, but none of the actual frontline team members. So this time, we were going to do it right. We decided that we had to involve the frontline team member voice at our table as an active participant and guiding us towards the right decisions. So we asked each PAR leader to go back and perform a standardized focus group with their team to solicit ideas that could fall into two buckets: patient experience or employee engagement. The PAR leaders were empowered with root cause analysis, 5 why training to assist in identifying the opportunities within these focus groups so that they could bring it back and we could instill some improvement efforts based on the ideas that we heard. After we aggregated all of these focus group ideas, we reconvened, and one idea really came to the top. One team member, a frontline team member, not a supervisor, not an official leader, recommended that a PAR-designed monthly curriculum for all PAR team members to participate in could be rolled out across the enterprise. So the curriculum would revolve around conversation and role playing to enhance team member communications and also engagement, getting them to start talking with each other more and working as a team in a unified front towards some of these improvement efforts. Monthly curriculum topics would be submitted by any PAR team member, and then one would be chosen by our group. Then we would invite that team member, along with any other teammates that they wish to bring from their work area, to meet with us and actually help design that month's session. So the role plays and the conversations that we were going to roll out for all 300 plus were single-handedly designed by a frontline team member that is a part of that group. So let's take a look at the data. So you can see in the chart provided on the y-axis, that is a percentile ranking compared to academics by Prescani. The blue bars are the CG-CAP's helpfulness from clerks and receptionists. The yellow bar is the respect and courtesy from our clerks and receptionists. And the green line is the domain percentile ranking. So you can see when we first implemented the program, there really wasn't much movement at all. In fact, we had one of our worst months ever the month after we launched the original program. We saw a brief spike and it got my hopes up, I won't lie to you, but it did not sustain. And then we came back to the table to really reinvent this, and that is where we developed that new PAR-driven curriculum that our frontline team members were delivering. They were the ones that were creating the content and then delivering the content to their peers. Once we implemented that new monthly curriculum, based upon that shared decision-making process, you can see our scores instantly went up and sustained for years. They still are sustained to this day, actually. So you can see a very dramatic, quick jump in the CG-CAP scores. As a result, we really effectively transitioned a majority of our patient experience and team member engagement initiatives from the traditional leader-driven, the top-down approach, to this new peer-driven design developed through a shared decision-making model. So within 3 months of launching this, we found a number of very positive outcomes. We put an emphasis on encouraging peer-to-peer recognition within our teams. So rather than a supervisor, manager, or director being the ones to continually deliver the recognition and submit nominations for our team members, we really encouraged our team members to drive peer-to-peer recognition. Instantly, we saw a 234% increase in peer-to-peer recognitions within the organization. We digitized all recognition in the health system. So prior to that, they were almost like Post-it notes that you could quickly write and hand someone, and we moved it all into our intranet. So when someone submits a recognition submission, which here we call a starburst, which is named after our STAR service program, it could be seen health system-wide. So no longer were you only recognized within the silo of your department, you were recognized across the enterprise. We introduced random drawings to reward not only those being recognized, but also those that took the time to submit the recognition, because that drives that peer-to-peer recognition motivating factor. And we also reshaped Friday meeting agenda templates to open with a gratitude moment. So this is used in health system daily calls, department huddles, and meetings every Friday. On every single agenda, it opens with a moment of gratitude. We also saw our PAR turnover rates in the participating areas steeply drop. We attribute this to the improved efforts to instill workplace pride by simply getting better about sharing our wins. We found out when talking with PARs, again, by having them at the table in the shared decision-making model, that they didn't know a lot about the departments that they worked in. They didn't know that one of their doctors had been recognized as with the Bedside Manner Award for the 5th straight year in Richmond. They didn't know that their department was named in the top 25 by U.S. News and World Report. So we had to figure out a way to start sharing our wins by socializing team members with physician awards, with department awards, with organizational awards. This really helped them manage up themselves, the department, and their colleagues when interacting with patients. And it really developed a sense of workplace pride. This reinforces what literature and what our colleagues across the industry have long said. Patient experience and employee engagement are not independent pathways to success. I often wonder if I had implemented the workplace pride and the recognition programs without the shared decision-making model, would the success outcomes still have been as fruitful? Now, it is it is difficult, near impossible to answer that question. But when I candidly mentioned these thoughts to one of my colleagues, she responded, well, Nathan, you know, a new initiative really loses the perspective of being burdensome when you're the creator of that initiative. That's it. We removed that top-down perception of burdensome initiatives by having the team members create said initiatives. Even though these new initiatives were asking team members to do more and be more involved than they ever had been, it wasn't viewed negatively. The shared decision-making model gave them the opportunity to create, to shine, and even shape their working culture really into what they needed, not what I thought they needed. And fortunately for our patients, these remarkable team members were able to simultaneously improve their employee engagement and the patient experience. So we recently held an appreciation event for our entire health system. We wanted to showcase the wonderful new shared decision-making model that these PARs helped create. We highlighted them, we highlighted their work. And as you would have it, we surprised them with ice cream and cake. And let me tell you, they ate it too. So thank you everyone very much for your time today. I'm happy to speak with any of you. I've offered my email address on the slide, so please don't hesitate to reach out. And I think at this time, I'll turn it back over to Carrie and Abraham and open up the floor for questions.
Excellent, excellent. Thank you very much, Nathan. I am checking the question box now to see if we have any questions submitted. I don't see any at this time, so as I continue to check, I will have Carrie Brady go ahead and facilitate our discussion.
Fabulous. Thank you, Nathan. Now I'm hungry for cake. But one of the things that strikes me about this presentation is that it takes us back to a foundation that you all identified when we started the year of patient experience in January, that you needed the most support from VHHA for staff engagement. That the other areas that we have here, leadership, patient family engagement, and effective use of data, you needed less support for, you felt more confident with. But staff engagement is really where most organizations needed to shore up support. So there are great lessons in what Nathan shared with us today about how you do that, and about how even when you think you're doing it, as he said, that first level step where he thought he was doing it wasn't getting really to the front line staff yet. So how do you get there? And we think there are ways to capitalize on this entire year of COVID. As Abraham said, we did not anticipate that that would overlap our year of patient experience. But there are ways, we think, to connect those things and to use this COVID experience to engage your staff differently. So we have a couple of polling questions for you. The first one is, we wanted to ask you, what effects do you believe the pandemic has had on staff engagement and patient experience? Do you think that staff are more engaged, less engaged, or have you not really seen any change? And we ask these polling questions every month in our webinars because we want to get a sense of what the statewide experience is. And depending on what you're seeing here, there are things that you can take advantage of, when we're going to talk a little bit more about that. If staff are more engaged, you can capitalize on that engagement. If they're less engaged, then there are ways to bring them back in. So we wanted to see kind of where you were at first on this question. We also know that based on last month, and Abraham, I think, are we still getting responses, or can you close this one out?
Yeah, I will go ahead and close it now. 5, 4, 3, 2, 1. It is closed. And so we will see if we can share the results.
Okay, so there's less engagement of staff for many of you, more than half, 55%. And some were engaged, and then some no change. So it is really important then, if staff are less engaged, to re-engage them and find ways to connect, as Nathan did, what the staff experience is, and the way that you are working with them with patient experience. You do not want to have this set up where it appears that these things are in conflict, that to improve the patient experience, you're actually placing more burden on staff, because that's not a dynamic that is ever going to work effectively when those two things are at odds. So we wanted to ask you our second polling question today. which is, have you asked your frontline staff to provide feedback on what has worked well during the pandemic? You probably have asked them what's not working well. We hope you've asked them that, but have you asked them what worked well? And the reason that we're asking you this question is because very often in doing focus groups with hospitals around the country over the years, I have heard a consistent theme that comes up is that people say that during a crisis, the hospitals tend to work better. Whether now, we have not had a crisis on the level of COVID where it's a pandemic affecting all hospitals at the same time. But this is in situations like hurricanes or other kinds of immediate short-term situations. What I consistently hear from frontline staff is that everyone is at their best during the crisis. So you have an opportunity here to ask what's working well, because you had to adapt to COVID, you had to change all kinds of policies and practices. So we're curious about whether you've asked them what's working well. Okay, you're split right down the middle, 50-50. So it would be interesting, and we encourage you to share this in the chat or to speak up here in a minute or two about what they're saying has worked especially well, because one of the HHA's roles, of course, is to gather what's working well and spread it far and wide throughout the state. For those of you that have not asked this question of your staff, we'd encourage you to ask them, because they probably will have really valuable and unexpected feedback to provide with you. On our last call, one of the questions that we asked was, have you implemented new strategies in 2020 to support your staff during the pandemic? 92% of the hospitals that responded to that question said they had implemented new strategies. It's really important that you ask your staff if what you're doing to support them is actually working, because that's another thing that often comes up in focus groups and in talking to frontline staff, is that the things that the hospital thinks they're doing to support them may not actually be having the effect at the frontline level that the hospital intends it to have. So you want to ask that question. And we've got a couple of ideas for you. That one way that you can do this, because Nathan talked about having focus groups where all the PARs went back and they had these consistent focus groups and a process for gathering this information from the front line. And there's lots of different ways to do this. But one way that you could do it that's a fairly simple and straightforward way to approach it is there's this concept of always events. It's a program that was designed by the Picker Institute, and now IHI has it. But the essence of it is that you ask your staff, what should always happen? So if you approach them and say, during this crisis, with the pandemic, what has worked really well? What made your lives easier? When we changed policies and practices and things like this, what made that work effectively? And you build from there. Another way to think about this is it's an appreciative inquiry type of model, which some of you may be familiar with. And the essence of appreciative inquiry is simply that you start with what's working well and build from there. In healthcare, as in many other areas, we tend to focus on what's broken and try to fix it. And in the process of doing that, we often overlook things that are working well or ideas that could work really well, but because they're not yet those evidence-based best practices, we don't gather them. So as Nathan pointed out, when they went to the staff, what was actually implemented and what worked and what was sustainable was an idea from frontline staff. It did not come from the published literature of what a best practice would be in this area. It bubbled up from the front line. So you want to make sure that you're opening up those lines of communication with your front line. And because during COVID, their processes have had to change, and this has significantly impacted the way that they are coming to work and the way that they have to work in your organization. When you start asking them the question about how this has impacted them, what you're doing, whether it's worked to support them, what is most effective, from there, you can build and gather some lessons and information that will help you build that roadmap for the future. That in any future kind of initiative, we need to make sure that we're building in what is working well. Obviously, you're also going to be interested in what's not working well and not repeating that. But it's an entirely different conversation when you start from what's working well. What can we build on? How do we extrapolate that into other areas? So we encourage you, however you do it, and whatever model you use, to really go to your frontline staff, have those conversations with them, because as the entire world has been changing under our feet in the last several months, it creates a unique and unusual opportunity to open up that dialogue in a meaningful way. And so we encourage you to tap into that now because the time is right, and use that to move your initiatives forward.
Carrie, if I may add on to that's an excellent point. And I need to be honest, when I approached a lot of these shared decision-making frontline team member groups early on, I was a bit nervous and fearful that they would take it in a direction that I really didn't think it should go, or that didn't align with best practices that I knew could be effective in their areas. And what I saw was actually quite remarkable in that they knew, they may not have known from an evidence-based perspective, but they knew some of the things and some of the aspects that needed to occur to make things change for the better. And I didn't run into any superfluous initiatives that had to be rolled out, really letting them engage and discuss it amongst themselves with minimal interference from myself yielded some of the best ideas. And it also, I think, further engaged them, because once again, it wasn't me interjecting what they should do. I really handed the microphone and the floor to them, and it was successful across the board.
And Nathan, actually, I see one question in the chat box, and it may be related to something you presented earlier in your comments, but someone says, can you provide us with an idea of what the topics were? How did you present curriculum topics to everyone? So does this question respond to something you said earlier?
Yes, absolutely. So we did go into these shared decision meeting groups with various topic ideas. So we already outlined one could be phone etiquette, one could be standardized greetings, one could be service recovery or de-escalation, and then the ideas would fall into these separate buckets where we would select one for the month. So I hope that helps answer the questions. And a lot of it was the group agreeing upon the right way to go about it versus a wrong way to say something, how to get the perception and the message across in the right manner. And sometimes it was identified that there was never even training, such as de-escalation. We always talk about service recovery, but what about de-escalation in that heated moment? What are ways that we can empower those frontline team members to navigate those very difficult conversations in a responsible, compassionate, and empathetic way, to where they're hearing and understanding what our patients and visitors are saying, not just responding to it.
Excellent, excellent. Well, Nathan and Carrie, we're at the end of another excellent patient experience presentation. We, as always, thank you for the hard work that you're doing. Thank you for contributing to this conversation across the Commonwealth. Want to remind our folks that we will continue this discussion next month. Had a slight change in our presenters, and we're very pleased to present next month Mr. Alan Lombardo and his team at the Sheltering Arms Institute here in Richmond, Virginia. They actually just went into a brand new facility earlier this summer, and will be sharing with us some of the insights they gained from designing their new facility for optimal patient outcome and patient experience, and how some of those concepts are very transferable to their colleagues across the Commonwealth. So please join us next month, September 24th at 12 o'clock noon, where we will hear from our colleagues at the Sheltering Arms Institute. That concludes our webinar and presentation for this morning. Thank you all for joining us, and please enjoy the rest of your summer that's left, and we'll see you in the fall, September 24th. Thank you all.
And go eat some cake.
And go eat some, what a note to end on.